Hello, everyone. Welcome to today's Epidemic Ethics regional webinar. It's the second in a series that will give you insights into the ethical challenges affecting different regions, both during and after the COVID-19 pandemic. Today's focus is on the Asia-Pacific region. My name is Teck Chuan. I'm a research assistant professor based in Singapore at the Center for Biomedical Ethics, National University of Singapore, and I'm joined by a fellow bioethicist from Asia-Pacific, Dr. Roli Mathur from India, Dr. Leander Marquez from the Philippines, and Professor John McMillan from New Zealand. They'll be tackling this very tough but important question: what should be prioritized from an ethical perspective to prevent, prepare, respond, and recover from future epidemics or pandemics? So to address this question, our panelists will discuss what the current situation is with regard to the pandemic preparedness plans in the region, and the key lessons we have learned from COVID-19, including any unique experience that could and perhaps should shape our future response to epidemics and pandemics within Asia Pacific and beyond. Some housekeeping first. For those of you who have been participating in epidemic ethics seminars, we are using the usual format. Roli, Leander, and John will be giving a 5 minutes presentation, and then we will jump into question and answer or Q&A. The questions, of course, come from you, so we encourage you to give your questions. So just to remind you that we are using the chat function to say hello, but if you have any questions for the panelists, please ask them using the Q&A function, which you see below in the Zoom. It will help me a lot if you also put a light on the questions you see in the Q&A. This will help me prioritize what questions to ask the panelists. Lastly, I should mention that the seminar is being recorded and will be available on the Epidemic Ethics website later in the week. The seminar will also be live streamed on the Global Health Network's Facebook page, and the recording will be available there as well. So to begin, let me invite our very first panelist to give her views and remarks on the topic. Dr. Roli Mathur. She's the head of the Indian Council for Medical Research Bioethics Unit, and she's involved in developing India's national biomedical ethics policies, as well as initiatives to build research ethics capacity in India. She's also director of a center as a WHO Collaborating Center for Strengthening Ethics, which is the first in Southeast Asia region. She's also a member of several WHO expert groups, such as the benchmarking tools for ethics committees. Right, over to you, Roli.
Thank you. It is lovely to be part of this webinar, and so I can begin with the first question that has been given to me, and that is about. So before I begin, let me thank the organizers for having me here. It would be lovely to talk to the audience about what were the kind of significant lessons and unique experiences that we learned from COVID-19. And I mean, in India and of course, in all of the Southeast Asia and Western Pacific region, for which this particular webinar is tailored, have faced similar scenarios. But speaking from the point of view of India, we felt that, of course, we all know that it was the worst kind of a public health emergency that had happened. And of course, there have been other, epidemics which have been there. But then the global responses that were needed for COVID-19 pandemic really actually exposed the inherent weaknesses that are there in our preparedness. We all thought that we were prepared, but we were not prepared, and we paid very costly prices for these mistakes. But it's very important to learn from these experiences and take preemptive steps before we land up in another similar situation. So one of the things I will be speaking from the ethics point of view and also from research ethics perspective is that what we learned was that we need people-centric approaches to win. People have to be first. We have to prioritize people, public health, talk about individuals, communities, groups, people. Often when research is done, it has an objective. And the objective is scientific, objectives that are there. But then we also need to think how we can build in the ethics element and the people-centric approaches in this. India being a very large country with diverse religious, cultural beliefs, practices, etc., several countries in one, we found that we lacked the public engagement part of it, to the public cooperation, the comprehensive methodology for communicating the risk involved or what the research was all about, talking about locally relevant approaches that were there. So these needed to be built into the research studies, which was done to an extent, but probably not to that extent, and which led to a lot of infodemic, vaccine hesitancy, and reluctance, because the need to address socio-cultural, fraternity, and besides all the barriers related to language and cultures, etc. Similarly, the social media, we found that scientists did not engage that well with the social media, or did not really do advocacy of what research. They had brilliant ideas, they were doing good quality work, research. However, they did not have time for this advocacy, to talk to people or to communicate it in a language or manner that could be understood, or to fight against misinformation or myths that were spreading around. And so that was the missing link that I think for the next phase, we must think about building it into that. We need to think about how we talk and communicate, how we build trust. It's not a one-time event. It's not just that you can build trust. It has to be over a period of time. So as and when research is being done, one has to plan how they can take communities along, stakeholders along the research process. Then the second point I wanted to make was about having robust science. Science has to be great. We saw hundreds of publications, thousands and lakhs, hundreds of thousands of publications came over this period of time. But was all this really good science? Was it able to generate meaningful data, real-time studies where they conducted for quality research outputs, involving enough integrity in the research processes? India was able to prepare its own, indigenously. ICMR was also part of it. NIV took the lead in preparing the vaccine, which was further scaled up, and it gave a good boost to the country in terms of realizing that yes, we can make our own vaccine. But and in addition, it was not only vaccine, but there were a lot of clinical trials, multicentric studies, surveillance programs, and India really emerged as a pharmacy of the world, actually, for its boost. It got a big boost to the manufacturing capacity. However, there was again a big outcry about the processes that were adopted, the fast tracking that was done for clinical trials. And that makes us very clear that there should be no shortcuts to good science. We should not make any compromises there to ensure quality in the outcomes. It is very important, therefore, to strengthen our regulatory frameworks, to strengthen our institutions to conduct good quality research, have that environment, enabling procedures, leadership, research governance. All this needs time now so that we are well prepared for this research. A number of studies also failed. We all evolved. There were hydroxychloroquine studies, steroids, and plasma studies, monoclonal antibodies, a lot of alternative medicine, immunity boosters, and others. Again, science was something that, the COVID pandemic showed us that important focus has to be science. Some success stories that we saw was we were able to expand exponentially expand the diagnostic capability in the country from 1 lab to 2,500 labs in about a year's time, which is a huge achievement. Then having, apps or online softwares where we could register for appointments for vaccine or even to generate certificates. Then ICMR set up the COVID disease registry platform. A lot of innovation, technology transfer, devices, Make in India startups were encouraged, and many labs were set up. So even the BSL 3 and 4 facilities have now been increased in the country. Nationwide testing portals were developed, biorepositories were planned. Then we also had, before COVID, we had a vaccine, very robust vaccination program for children, which had to be scaled up to adults as well. And the initial months saw that there was huge vaccine hesitancy in the country. People were hiding, jumping in the water bodies to hide from people who were coming to give vaccines. But however, we saw that this greatly was able to, we could improve on that vaccine hesitancy by a lot of engagement activities, by a lot of advocacy that was done not only by the government, but also by others, public sector and private sectors and other philanthropic organizations. And in fact, India became one of the fastest countries in the world to reach 4 million vaccinations in a matter of 18 days itself. Then the next point I want to make is about ethics review during emergency. Now, ethics committees also got initially stuck up in how they will do review because they needed to have physical meetings. But then very quickly, ICMR came up with a new national guideline for ethics committees and online ethics committee reviews. It suggested about unscheduled meeting. It made suggestions about having electronic methods for informed consent. And I think that was, again, very useful. And also ICMR, developed SOPs for emergency ethics reviews, encouraged the use of common forms, which helped to standardize the submission process to the ethics committee for institutions across the country. So some of these initiatives really helped India in a big way. I think with that, I'll stop now. Thank you. Thank you all. I hand it over to you, TC. Thanks.
Thanks very much, Roli, for the insights. A lot of things going on here about trust, about even getting trusted people as like scientists to come out and advocate. And this seems to be focusing a lot of capacity building in many ways that I think weren't previously emphasized before in public health. So feel free to ask questions, all the participants, and put them in the Q&A. I'll invite the next speaker, Dr. Leander Marquez. He's an assistant professor at the College of Social Sciences and Philosophy at the University of the Philippines, Diliman. He serves as co-chair of the working group on bioethics of the Association of Pacific Rim Universities, APRU, at the Global Health Program. And he was also a junior ambassador for the Philippines for the Universal Scientific Education and Research Network. His research interests include epistemology and bioethics, and very interestingly, philosophy for children and philosophy and popular culture. Leander?
Hello, TC. Hello, everyone. Thank you for having me here today. So let me just have a few seconds to share my screen. Okay, so what I'm going to share with you today is basically what we have experienced in the Philippines, but I also did a bit of research on the experience in Southeast Asia because there were lots of common experiences in the region during the COVID-19 pandemic. And let me begin with what happened. So what happened in Southeast Asia during this time? So during the onset of the COVID-19 pandemic, there were very few recorded cases in Southeast Asia, and it appeared as if the virus was being contained and will not pose a significant problem. From January 2020 until early March, there were almost no reported cases of COVID-19. The very few reported cases appeared isolated from each other. For instance, Singapore and Vietnam were quick to respond to the first wave of cases, which began in January 2020 through contact tracing, surveillance, quarantine, and restricting travel. Singapore developed its own testing kits, and Vietnam tapped their retired medical professionals as well as medical students to control the spread of the virus in the country. Other nations in the region, they did not have any reported cases for months. An example is in the Philippines, in my country, where the first confirmed COVID-19 case was reported on March 2020. So this was 3 months after the first case was reported in the world. It seemed as if COVID-19 was under control in Southeast Asia and the rest of the world can learn from its practices. So was Southeast Asia really a role model in managing COVID-19? But that's my question. However, in by mid-March towards September 2020, reported cases in the region shot up from tens to thousands, even for countries that was quick to respond, such as Singapore and Vietnam. As it turned out, the situation that COVID-19 was under control in the region was a mere appearance. It was an artificial situation due to the lack of government attention and action that was given to the risks as well as questionable decisions, especially concerning travel of foreign workers. The fact is that the COVID-19 management situation in most nations in Southeast Asia was plagued with slow detection, porous response, and denial. In Cambodia and in the Philippines, for example, the threat of COVID-19 was downplayed, if not utterly dismissed. For instance, travel and gatherings were not restricted in the Philippines. Those who wore face masks were ridiculed for being paranoid, and announcements from the government were often contradictory and confusing. Uh, SOPs and protocols were also relatively relaxed in Malaysia during festivals, and the Cambodian authorities also did not restrict travel and even went as far as traveling to China to show that there was nothing to worry about. Indonesia also was uncoordinated in responding to the situation, as it was not clear who was in charge, and economic consideration were taken to be more of a priority than health concerns. Myanmar was in denial of the threats of COVID-19 and even branded it as fake news. Thailand also had an initially slow response to controlling the spread of the virus, but sprang into action due to increase in cases and public criticism. Interestingly, what appears to be common among most, if not all, of the territories in Southeast Asia was the fact that the COVID-19 situation was used to give almost sweeping powers to their respective militaries, which enforced physical lockdowns. Some even went as far as censoring media and threatening arrest and detention for spreading fake news, which many feared as an excuse to round up political detractors and critics. Ultimately, the health crisis was even exacerbated by politics. So, given that, what were the lessons that we learned from this experience? So, the experiences and heartaches of the COVID-19 crisis gave nations in Southeast Asia very valuable lessons because the virus did not spare anyone. Rich and poor, government leaders, and humble citizens lost someone to the virus. This is, of course, apart from the economic impact that it has brought to nations which are mostly still developing. The experience in the region underscored the importance of strengthening the health sector. This evidently involves several factors such as increasing and diversifying health funds, investing more on healthcare workforce, especially in the Philippines where medical professionals leave the country for better opportunities in the US, Canada, or Europe, and also building digital health infrastructure, as this was proven to be very effective in making health services accessible if physical access to these services is not possible. Furthermore, the importance of regional cooperation was highlighted by the crisis, especially when it comes to regional health governance. Since trade and travel between and among nations in Southeast Asia are vital, regional progress in terms of controlling the spread of COVID-19 cases and keeping the economy afloat can only be as strong as its weakest link. The shared norms in Southeast Asia with regard to monitoring, reporting, sharing, and the like have also helped the different nations, from preventing an even worse outcome during the crisis. Today, a roadmap for health security and resilience was built to help protect the people and economies in Southeast Asia from the adverse impact of public health crisis. The roadmap was a product of the lessons learned during the pandemic and in consultation with countries and experts in Southeast Asia. A roadmap for diagnostic preparedness is also being prepared for rollout to guide nations regarding sustainable development of laboratories and systems, as well as improved surveillance and response to diseases and public health emergencies. Overall, the COVID-19 experiences in Southeast Asia have brought greater and deeper cooperation among Southeast Asian countries and citizens within these countries. Although further and more concrete actions to prevent future health crises such as the COVID-19 pandemic are yet to be seen from leadership of Southeast Asian nations. So that's it for me. Back to you, TC. Thanks, everyone.
Thanks, Leander. So one question I do have for you, and maybe you can address that later, is the extent to which ethics is incorporated in those regional governance and roadmaps. But for now, I'll turn to our last speaker, Professor John McMillan. He's a professor of bioethics at the University of Otago in New Zealand. He's the editor-in-chief of the Journal of Medical Ethics and chairs the National Ethics Advisory Committee in New Zealand. And he's also a member of the National Screening Advisory Committee there. His research interest includes public health ethics, philosophy, and ethics of mental health and research ethics. Over to you, John.
Thank you, VT, and thank you, Kevin, and others who have organised this meeting. Leander and Roli, it's been very interesting to hear from you about your experiences, and there's certainly some things that gel with things that we've seen in New Zealand. So I've tried to think about one big lesson that I can derive from looking back in New Zealand, and one, I guess, big worry about looking forward. So I'll talk about both of those. Sorry, I'm just trying to get to my next slide. Right. Yeah. So one of my roles is I chair the National Ethics Advisory Committee, which is a committee that advises the Minister of Health in New Zealand. And back in 2007, NET published this report, Getting Through Together Ethical Values for a Pandemic. And it was kind of prescient. This is quite a long time ago. And it outlines a set of principles with illustrations for issues that can come up during pandemics, and a structure for thinking through decision-making under conditions of pressure. So in 2019, before the pandemic, it had been decided that we'd do a new version of it. So we were working on this during the pandemic, and have thought about this some more. So the New Zealand pandemic experience, right at the beginning, we had a very charismatic Prime Minister and a very good Director General of Health who reacted quickly in March. And in 25th of March 2020, we went into a lockdown. I was thinking, Leander, as you were talking there about how the military became involved in a number of Southeast Asian countries. In New Zealand, one of the extraordinary things about this was that the Prime Minister said, right, a few days we're doing this, all you people are staying at home, and people just did it. There was very little enforcement and very little rule breaking. It was kind of extraordinary. And so in that first year, the pandemic response was impressive, and people were talking about it on a worldwide stage. So that kind of looks like a good thing. The Labour Party, which was the party that Jacinda Ardern was the leader of, were rewarded later on in that year with a landslide election victory. So New Zealand has a MMP system of government, so it's quite unusual for one party to win enough votes to govern on its own, and they did. So they had 64 seats, whereas the centre-right party had 35. But the story didn't altogether have a happy ending, and things developed in a less positive trajectory. One of the things that emerged was that the problems with health inequities in New Zealand became very apparent and became amplified during the pandemic. So here's a brief discussion paper from the BMJ where they're talking about how the COVID-19 strategy failed Māori in New Zealand. So with the rollout towards the end of October 2021, it was clear that 49% of Māori were fully vaccinated compared to 72% of the entire eligible population. It also became clear that Māori were 2.5 times more likely to be admitted to hospital than non-Māori, and 50% more likely to die. And so they estimated the risk of hospital admission for COVID-19 for a 40-year-old Māori and a 35-year-old Pacifica is approximately equivalent to the risk of hospital admission for a 60-year-old European. In understanding this, it's important to see it within a historical context. I was thinking about Roli's remark about the importance of a person-centric approach to this. Māori can remember back to the 1918 epidemic, flu pandemic, which killed 1 in 20 Māori. And so it was very difficult when the pressure came on to do things that would engage with Māori. And because public health policy people in the government were making decisions under pressure, it was a one-size-fits-all solution. So one of the key lessons for us from looking back is that the inequity fault lines that exist in Aotearoa and New Zealand were pulled wide open during the pandemic. So that the big learning from looking back is we have to prepare now with responses to future public health crises that are, in Roli's terms, person-centric and work for all communities within the population. So that's one big learning for us. The second is this. So we just had an election in New Zealand, and this Labour government, which had this huge majority, has been completely turfed out. So they are going to get 34 seats in Parliament, far below the 65 that they won after doing well at the start of the pandemic. So for whatever reason, the government that did so well in the early stages of our response has been punished quite solidly by the electorate. Now, we had last year and the year before that, there were people camped out on this is at our House of Parliament. And as you can see, it's a very unusual sight for New Zealand. We've got riot police there trying to remove protesters. And they were COVID protesters. They were protesting the pro-freedom protests. They're protesting lockdowns and other restrictions on people. And there's reason to suppose that some of the people were from some religious groups. There's some other people who had different views about healthcare and anti-vaccine, but there was also a significant, looks like there's a significant contribution from the far right and the alt-right who had managed to stir up this feeling. So the other thing that's happening, we were doing a consultation on the new version of our pandemic preparedness document. So this was during about the same time. And as you can see, we had proposed 6 ethical principles for thinking about future pandemics: health and well-being, equity, katakitanga, manaakitanga, tika, and liberty. Now, I've just put the percentages of responses to these. So 26 agreed with katakitanga, 31 with manaakitanga, and lots of people agreed with liberty. What happened with the consultation was that we had hundreds of responses from many of the people that would have been at that protest. So it became a challenge to incorporate public consultation within this document that was trying to come up with a structure of thinking about the ethics of pandemics. So I think looking forward, the big thing that I'm concerned about, and the big thing to try and mitigate in the future, is something that both Roli and Leander mentioned, which is how to frame evidence-based ethical guidance in a context of distrust, polarized views, and misinformation. And if any of you have any brilliant ideas about how we can counter misinformation, I'd be delighted to hear them take them on, because I think this is likely to be the big challenge for us in public health ethics over the next few years. Thank you.
Thanks, John. So one quick question for John first. You spoke about some of the values that are more specific to New Zealand, like Koha Te Tanga. I hope that I pronounced that correctly. I'm not sure whether you kind of explain what those values are.
Yeah, so rather than just, I mean, in sort of print, I've been a critic of principles-based approaches to ethics, but I think in this context, they're quite useful to talk about some high-level values and to show how they might apply in different situations and be weighed up. So that's one of the reasons for having a principles-based approach. Tika is interesting. So a number of the Māori ethical principles or concepts are different from, autonomy and beneficence, in that they're not so much high-level, very general, abstract norms. They're talking as much about process and a way of doing things. So Tika doesn't have a direct translation into English, but it's a process principle. It's about the way of going about things, which is correct. So often Māori will talk about relationships and the importance of relationship building as a way to get to the right outcome. If you take ideas like that and think about what's going to help with health inequities, distrust, misinformation, relationship building and going about things in the right way, I think adds so much over above thinking about liberty and well-being. Yep.
Yeah, thanks for that. I haven't seen any question from the Q&A, so I'll just go ahead and ask a question maybe for all the panelists to answer. And I'm drawing from what John just said, but the importance of considering norms and values that might be influencing our behaviors within a given cultural context. And maybe there's something that's unique to the Asia Pacific region. And I understand that Asia Pacific region is very big. There's South Asia, there's Southeast Asia and so forth. I'm just wondering, maybe from Leander and Roli's perspective, were there any specific cultural values that were perhaps not taken into account of during the pandemic? Roli?
Okay. Thank you, TC, for this question. So maybe I'll just tweak your question a bit and I'll talk more about how to build into the ethics considerations into the public health system, because that is where we feel that in India we really need to invest something. That what has happened is that the decision-making processes that exist at the public health level and the various approaches that are adopted in making those policies and decisions often do not take into consideration the social, cultural, and other dynamics that are there. And then, being such a large country with variety of people and populations, it is not very easy to find a single solution for the masses. And when there is no prior experience, this becomes extremely heightened and difficult, actually, to while it involves multiple stakeholders as well. So there are a number of biases that creep into these decision-making processes. So from the scientific perspective, what I would like to talk is about the importance of some evidence-based decision-making, where we rely our decisions on some prior limited evidence that may be there, and also to see how ethics considerations go into the way these decisions are being made. So that is a way forward to make things more accountable and more transparent in terms of having clear processes that are available to others to understand that why exactly a particular decision has been taken and how did we reach that discussion. So I think some of these approaches will help to bring in transparency, because there is no one rule that fits all in India. And it is all very gray also, because something may work in some circumstances, may not work. But then if there is an improvement in the way we take these decisions, if there is transparency, then I think it will help to build trust as well as to have better outcomes from these steps that are taken. And it will also help to build into the local context, because sometimes the local context doesn't go. The decisions are taken in a hurry, lack of prior experience and all that. So I think some of these are my thoughts, and then I'll hand it over to Leander, please. Thank you.
Thank you, Roli. So in the Philippines, the first wave or the first year of the pandemic was really hard. This was the time when lockdowns were strictly enforced throughout the country. And there were reports wherein families get hungry, not being able to eat for more than a day because people cannot go to work. There's no way to buy food. So really, it was really a very sad experience for everyone, especially those who are the poor members of the Filipino society. Now we have in the Philippines this value we call bayanihan.
Sorry, Leander, you're muted.
Yeah, from the word bayani, yeah, which means hero. So our notion, our concept of bayanihan is when communities come together to help each other, wherein we do not wait for the government to help us. We come together as a community to help ourselves. We act as heroes in our own right, like the Avengers. So what we did, or what the experience in the Philippines was, there was actually this community pantry movement in the Philippines that became really popular. It was started by one person, uh, a lady from Metro Manila, a graduate from our university, wherein she placed a table in front of their house. I think it was in a public place right beside the street. And she put there lots of things, rice, fruits, groceries, wherein people can just get what they need. And people can also donate what they are willing to give. And that particular movement, that in the spirit and in the spirit of bayanihan, became a national phenomenon. So left and right, the various community pantries were popping up and helping others, because it was really taking too long for the government, for example, to give people the aid that they needed. So it was something that was very inspiring for our nation, but also it was also one thing that was very romanticized, because it appeared that okay, why should the government help you if you can help yourselves, right? So it's something that was somehow it was something good, but it was also something that is prone to abuse. So that's our experience in the Philippines.
Yeah, perhaps the lesson is that everyone should chip in and not just wait for a top-down or a bottom-up approach. We have a question from Diego Silva, who I believe is based in Australia, Sydney. It's a question that's a variation on John's question. And this is his question: how do we get policymakers, members of the general public, and scientists to recognize that epistemic values shape data collection and analysis, which then affects the manner we generate ethics-informed policy? John, would you want to address that?
So I take it that the point is that all evidence that's put forward will have some sort of epistemic framing, and there's no such thing in this context as value-free or value-free science. Yeah, I think I was just thinking back to the sort of really heated parts of the pandemic response, and it's probably the case in Australia too, where the evidence was so new and at such a sketchy or so provisional, and decisions need to be made that a sort of fine, more kind of fine grained evaluation of it didn't seem to be a feature of that time. But as things have progressed, there certainly are a number of issues where that epistemic framing comes into light. And I was thinking about a paper that came out in the JME a year or so ago that was looking at the evidence around vaccine mandates for American university students. And it was arguing that the evidence wasn't there. And there's a bunch of very scientific people who had a completely different view of the evidence. And so, you know, is the epistemic weighting in those cases, is it because of some values about what we should be doing with respect to vaccine mandates for university college students, or something about not undermining an effort? But it definitely wasn't just a reading of the literature. Yeah, so I don't know. I mean, I think to me that was a kind of illustrative example, because you had straight numbers people having very heated different views about the data sets. So I don't know, maybe we just say, look, there is these examples where these experts have said very different things, and we just need to be aware that even very good scientific people might have divergent views.
Yeah, I think one way to answer that question is potentially what kind of evidence that policymakers rely on. So you might expect them to ask modelers to model, infection rates if they do one policy then the other. But rarely, I think, do they ask modelers to look at the effects of inequities if they pursue one policy versus the other. So I think that's maybe that's how potentially our values shape the way we look at the data. And any thoughts from Roli and Leander?
Well, like you said, TC, I think this needs, adding to it is that this, we need to build networks, channels. We need to work with people, think about partnerships, collaborations to bring those expertise on board, have more people engaged to bring, clearer thought processes to whatever decisions are being taken. And in order to prepare for the future pandemics and thought processes, like you rightly said, there could be so many epistemic or other reasons or biases, or we have seen that all happen. That is a lot of experience. There are examples and examples from India that can be given on what went wrong. But how do we move forward is the big question, that what is it that we can do that in the future policy making, what kind of structures or what kind of frameworks? Of course, we don't want to go with a tight framework, but then what kind of policy makers may be completely non-involving any of these thought processes on board, because they have practical, political, and other funding and other limitations in which they have to function. So what is the way forward in which we can do a better engagement and better advocacy for what our needs are? How do we make the public also feel responsible, and how can we build these networks and channels so as to rightly communicate the difficulties to the right people? So I think a lot has to do with a lot more investment that has come to research. I'm talking from research point of view, sorry about that, but that's how I think. But if you look at the investment for research, it's really minuscule, looking at the whole investment that goes in other areas. Health, of course, there is some, but health research, it's a meager fraction. So there's a lot more effort and a lot more things that investment is needed to build into that. Thank you.
Right.
Yeah.
What I can add is, I think, the importance of education. I mean, if our government leaders, those who are involved in coming up with these policies, are not educated in the sense that they do not by themselves believe in the importance of research, what we can learn from the efforts of scientists in shaping public policies, then I think they're the way that they would shape policies will just be based on what they feel at that particular moment. And in our experience, that happens a lot. There are, for example, politicians in the Philippines who would argue with experts, argue against evidence, against data, and that um, ruins everything, right? And in terms of policy, and of course, in the long run, that would have a drastic effect on the population. So I think education is very important, not only for leaders in the government, but also people, because it's the people who would tell the leaders to listen to experts, especially if lives are at stake, right? So yeah, that's it for me.
Thank you. There's a question from in the Q&A talking about responsibility. Because of the obligation to protect oneself as well as one's patients from infection during shortages of, let's say, PPE, whether this is our ethical obligation, the staff of the institution. I just want to reshape this question into, after all, it's about resource allocation and, the need to sort of educate not just healthcare professionals, but potentially the public on what their responsibilities are during a pandemic. And perhaps it's something that ought to be done as part of preparedness as opposed to during the pandemic itself as part of the response. Do you have any thoughts about this, Leander, given that you are, very invested into education and philosophy?
Yeah. For me, of course, do no harm, right? It's paramount. So if the resources are there, the staff of the institution should make use of it. There should be no shortcuts, especially if any deviation from protocols would result to potential harm, for instance, to the patient or to health professionals. But in my experience, in our experience here in the Philippines, there are health institutions which do not have the resources. So it's just not the responsibility of the institution, but also the responsibility of those who can provide funds for the institution, especially in public hospitals, in public healthcare institutions, wherein funds are very limited. So it all boils down to the proper allocation of resources, because I'd believe that if the resources are available, our healthcare professionals would use these resources for the good of the stakeholders. Thank you, TC.
Taking this ahead, it is, I agree with you, Leander, we need the resources. But I think we somehow also need that will to invest more. Because like I think I did mention a bit earlier that, researchers work with the mindset that, they will do the research and publish. So it's not my responsibility beyond that. And similarly, all stakeholders feel that, the funding agency thinks their responsibility is to fund. The institution has its own point of view. The ethics committee looks at it only from the ethics. So there is no comprehensive structuring of these responsibilities in that sense, that how actually is this going to go back to the people? How is it going to be translated? Yes, it would get a good publication, but then how is it going to inform policy? That link is what I think is slightly missing, and we need to really work on that link in converting our science to policy. And I don't know who is supposed to be doing that. And we feel that researcher plays a very important role there. But researchers are often bogged by too many other things, and this may not be in the priority of things to do. So we need to plug in that gap to make sure that the research outcomes get out. And so for example, when an investigator is writing a proposal for a research grant, they will not build this into the budgets. So if there is no budget for that, it does not come as an outcome. So these things don't come in those normal processes of research studies. So at ICMR, we are a funding agency, and we don't see that the public engagement, communication, returning back to benefit sharing is part and parcel of research projects. Thank you.
Okay. I have a question for you, Roli. So it's about people-centeredness, and I've seen you I've heard you give many examples during this webinar. You know, asking research scientists to talk about how their findings translate into policy and things like that. Could you elaborate more about people-centeredness? I mean, how should this be implemented or practiced in all the various stages of pandemic preparedness, response, and prevention, and so forth?
Tough question, because research involves a lot of planning, and I keep talking about it. Research is not that simple. When we talk of public engagement or building trust, this is not a one-time event of going to a community, doing research, and that is it. It takes time. It takes years and years, and probably, that institutions also need to support the investigators and to provide them with the wherewithal to be able to do this. Research involves teamwork, networking. It requires multiple people bringing multiple facets of the research to make it a complete package rather than bits and pieces. So I think institutions have to invest more and support the researcher in doing it, because as an investigator, one feels that, what to do and how to do. So, and it's, like I said, it's not a one time. So this enterprise has to be strengthened in a big way. We do not have, at least in my country, I don't see structures that support research. In the academic institutions, there's a small requirement of doing some research. And it's the focus is not research. The focus may be on teaching or clinical practice for medical doctors, for example, in medical colleges or academic institutions. So research, how do you come to that? Or research focus is very important, even though there are a number of research institutions also in the country, but probably we need a lot more to strengthen them. Thanks.
So I'm going to ask John this question about ethics frameworks, and this question is linked to a comment from one of our participants before the webinar, and he or she is trying to improve their understanding of ethical frameworks and their practical application. There have been some doubts about the utility of frameworks during pandemics. They are quite broad, and they really depend a lot on the evidence, political issues and so forth in order to sort of implement policy in a practical, visible, and just way. I'm just wondering if you talk about ethical principles, health, liberty, equity, and so forth. I'm just wondering whether or not you agree with the statement that or the claim that frameworks are not that useful, and we should look at alternative ways to incorporate ethics into the response.
Well, the different kinds of ethical frameworks that we used during the pandemic. So there was a kind of quite a large industry that developed around different forms of ICU triage. So initially that was the thing everyone was talking about. And of course, ICU triage is in a way, the thing at the bottom of the cliff in terms of the ethics of a pandemic, and a lot of the things we needed to think about a bit more we're earlier on. And so ICU triage, they typically will be an algorithm which you have inputs into it, and it ranks people. So that's one kind of ethical framework. Then there are other structures which are sort of decision-making ones where you feed in inputs and work your way through and end up with a solution. And some of those I think are quite good. I mean, it depends what you want out of it. I mean, it's not going to tell you the right thing to do, but if you have an ethical framework that describes some central values that are important and generally important and likely to be at stake for an important public health ethics decision, and you talk about how they can apply in some different situations and be weighed up. So you've got some exemplars that talk about this is what this means in this public health ethics decision, then someone who's faced with a public policy decision and has this evidence and this recommendation from epidemiologists about where things should go can use these values as a way of as a check upon, am I weighing things up in the correct way? So if you think of an ethical framework as a kind of another heuristic that you can help think things through and justify a way forward, then I have value. Then they have value. But if you think of them as things that can help you produce the right answer, there are a few of those. There are a few algorithms of that sort. But in general, a lot of the kind of hard work has already been done, because that tends to be the evidence that you're feeding into it at the beginning. So I think they can. It just depends what you want to get out of them and what kind of ethical framework it is. The one that we've produced, I talked to they have a Royal Commission of Inquiry into the COVID response, and it looks like the principles that we've come up with in the NEAC document will play a role in thinking about public health preparedness in New Zealand. So likely to feature in our future planning.
Yeah, that's very helpful. To really understand what work they're doing in terms of normative justification and all that, and all that, and not place all the work on ethics frameworks.
Well, I was thinking about what Leander and Roli were saying about the importance of transparency, and if you can help to explain why you're doing this, and you bring in some values that people can relate to, and say we're doing it in part because of this concern about people's well-being. We're not doing this because we're concerned about constricting their liberties too much. That's going to help with the process of transparency, communication, and trust building.
Yeah, so the procedural as well as the substantive values. We're running out of time with exactly 3 minutes left, so I'm going to give each panelist 1 minute to talk about this particular question. What priorities should your country or the region, Asia Pacific, focus on for preparedness and prevention of the next pandemic or epidemic? I'll start with Leander.
In my experience, I think it is really support for research and healthcare infrastructure, because that, I think, is where we failed the most as a nation. So we relied on the help of other countries, and sometimes the help comes too late, right? So when we need it the most, we don't have anything. We are not capable of producing, for example, our own vaccines, and our funds were diverted to other things instead of healthcare. So that is, I think, the priority on resources for healthcare is very important, at least in our situation, as well as transparency as to where the funds are being used, because that was also a big issue in our country. Yeah. Thanks, TC.
Roli, John, who wants to go next?
Okay.
I was going to say co-design of ground-up public health initiatives, particularly with Māori and Pacifica, is probably the way to build capacity here. And Leander and Roli both mentioned that too, involvement of other people in research. I think that's critical for us.
Roli, you have the last word. Yeah.
Yes, agree with you, John. And then I think we need to identify the priority areas for research, find funds, establish financial and administrative mechanisms, regulatory frameworks, guidance frameworks, so that we can enhance the quality and quantity of the research outputs that could be done, and improve collaboration, partnerships, networking, build public trust. Try working on that, start working now, and looking at ways on translation of the outcomes of our research. Thank you.
Thanks, Roli, John, and Leander. Thank you, everyone, for such engaging talks. I've learned quite a few things. I want to thank all the participants also for joining us. Just to share with you that the recording will be available soon on the Epidemic Ethics webpage. And please do check the our website for future seminars, and you can follow us on Twitter, LinkedIn, Instagram, and Facebook. So thank you everyone for your time again. I'll end the seminar at this point. Thank you.